Okay, well, welcome to Ask an Orthodontist. And today I have the great pleasure of interviewing Dr. Christoph Moschik. Um, Christopher did his dental training at the University of Graz in Austria, and then he did his 3-year specialty training in orthodontics in University of California in Los Angeles with Professor Juan Moon, who was the developer of the MSE appliance, which we're going to deep dive into today. And Chris graduated from UCLA in 2018. He's a diplomat of the American Board of Orthodontics, an affiliate member of the Angle Group. During his training at UCLA, he focused on MSE treatment, and he researched about MSE treatment's effects on the maxilla, on the nasal cavity, and most importantly, on breathing functions. And I'm going to share with the audience who are interested the links to his published papers. Chris currently lives in Munich in Germany with his wife, who's also an orthodontist, and he works full-time in his own private practice, which is called Relax and Smile. Any MSC patient that contacts me who lives anywhere in Europe, and I have a lot really from the UK, I ask them to see Chris, and they're always eternally grateful and very happy with the outcome. Chris, I know from our dialogue, you've completed nearly 500 cases in MSE, and that backed with your training under the developer and your research, I think probably makes you one of the world's experts in the field. So thanks very much for taking the time. I know you're recovering from a cold, so I hope you can make the distance, because what I wanted to do is really, I've put together with my marketing people the common questions that patients ask about MSE, whether they ask them through social media or at my initial consultation. And so I thought we could both answer them, with the view of answering them maybe technically, but not so technically that it goes over the head of the average patient. I know for the audience, maybe dentists, Chris Mosch has done much more depth presentation, which he recorded as part of our COVID seminars, and that's a free lecture on the website, which is called EODO Teachable. And in that lecture, I think it's a much better explanation of the technical aspects, where Chris describes planning and how to place it, shows many cases. So for those people who want more information after this interview, I would suggest you go to, it's called eodoteachable.com. And if you look under the heading of Treatment with MSE by Christopher Moschik, and it's in part of our free lockdown CPD, where we did a lot of taping of lectures to give back to the profession when people weren't able to work during the COVID period. So with that introduction, let's get the ball rolling. I guess the most common question people want to ask is basically, what is maxillary skeletal expansion?
Yeah, thank you, Derek. Thank you for the nice introduction and inviting me to this podcast and to the talk. And yeah, what is maxillary skeletal expansion? The term was coined by Juan Moon when he initially started to do expansions with mini screw assisted expanders, and noticed there is more change than just actually moving the teeth or the palate, as we many times did in orthodontics before. And especially in adults, we noticed having effects on the midphase, on the maxilla at all, at the whole bone itself. And that's why the term was coined maxillary skeletal expansion. So it is.
I almost tell people, I call it now midface skeletal expansion, because I want to differentiate it from all the other MAPIs on the market. So maybe you could tell us a little bit about how it actually works.
It works that you have the MSE expander, which we place on the pallet and insert with mini screws for skeletal anchorage. And the idea is that we truly have bone anchorage. And with the expansion, we move the bone itself, not the teeth, and thus creating the midfacial effects you've talked about. As you know, in your own clinic, you have many cases doing it. This is usually how the MSE then works.
And I guess I want people to understand that if you're a younger patient, then normal expansion gives you similar effects. But the older we become, the more sutures, they don't fuse. That's one thing Moon has taught both of us. Sutures never fuse, but they certainly become more intertwined and harder to separate. So that's why we need to put these effectively what we call mini screws in the palate. Can you tell me what clinical indications you would recommend for MSE?
Yeah. Of course, we have the classic indications like crossbite on one side or both sides. A lot of what we call curve of Wilson, meaning lower teeth being tipped inside and the upper very much tipped outside to compensate, to match the width of the lower jaw. And I like to look at the width of the top jaw compared to the bottom jaw. And if I see a larger discrepancy there, this is usually a point for us to look at. The not so conventional indications are like recessions on the top jaw, on the outside teeth, when the gum is receding due to unfavorable force vectors due to the tipping. Sometimes we have patients with breathing problems. Then we talk with them deeply about how MSE can affect and try to give them some testing kit beforehand, before doing expansion, to see how much effect it will have. And later on as well, we have sleep apnea patients where MSE can play a big role in helping alleviate the problems and help them with the symptoms. How is your experience with?
I think I might hop in by saying that when I went to traditional orthodontic school, we were taught never to expand unless we had a crossbite, but we were never told to really analyze the angulation of the teeth. And you're quite correct. When I see a lot of crowding in the lower jaw and the teeth lean in, I kind of visualize now, what would it look like if I upright those teeth, those posterior teeth? And as I do that and get nicely well-aligned arches, of course, the upper jaw doesn't match. So effectively, it is in crossbite, but it's just that nature's had so much compensation of the lower. And I think that's a big point. I think all those points you mentioned were absolutely spot on. But I would also say I get a lot of patients who just want a wider smile. They don't like their buccal corridors, and the older you get, the harder it is to just move teeth to reduce that buccal corridor, because we tend to then push those teeth out of the bone and cause more recession. Whereas if we change the true skeletal aspect, then we get it. So not that I am promoting MSE purely for cosmetics, but I can tell you a lot of women come in their 40s and they want to have that midface back. So I've almost termed a brace lift, right? Because
Absolutely agree.
yeah, and these women, they of course, I've never met a woman in my life who doesn't want to look younger. There's no doubt about that. And they become very embarrassed, because when they go back, amongst their social group, and friends say, "What have you done? You've obviously done some sort of cosmetic surgery. It looks good. Can you share who's doing it?" And then they're very proud to say, "No surgery whatsoever." So now let's just dive into the other side. I mean, people listening to this are probably saying this is too good to be true. Now, what about some of the potential side effects of MSE?
Yeah, of course we need to talk about those ones, and I'm happy you bring it up, because with MSE, I think we need to be careful during the expansion. It need to be well controlled and guided by someone with experience. When we do the MSE expansion on a more slower pace, it can be very well controlled. But side effects which are commonly seen include the potential of asymmetry. This is something we'll see many times. Then, of course, there can be some discomfort during the initial phase after placing the MSE. When you start activating, usually then it fades away. And beside that, if the expansion doesn't work because the bone is simply too hard or is stronger than the appliance, then there is a risk of tooth tipping or infection, or like the MSE pinching into the tissues causing pain and discomfort. But this can always be controlled by regular checkup. We many times do it virtually through dental monitoring, online checkups. And if it's monitored well, that can be very well controlled and managed before it actually happens.
And I think I always warn my patients there's obviously going to be some temporary changes in their speech. Their tongue has to adapt to this appliance being in the mouth. And the big thing I warn them is that, what you and I like is we see the gap. Many patients hate the gap. So I've had some patients who kind of stopped turning because the gap was getting too big. And I said, oh my God, what are you doing? Later, I have a good friend who's a cosmetic dentist who quite happily bonds some composite on those incisors just to make the gap not look as big, just so that the patient keeps turning. So I guess that's the two side effects that I'd like to mention on top of that. The other question I guess everyone wants to know, how long is the duration of MSC on average?
Yeah. So we distinguish the active expansion phase and the orthodontic treatment phase afterwards. And depending on the amount of expansion we need, the active expansion phase can be anywhere between 3 and 6 months. If we aim for 12 millimeters of expansion, which is quite a lot, then we take our time and allow the bone to adjust to follow those large movements. And we might take 6 months for the active expansion. Also, the orthodontic treatment phase depends on how much expansion did we do, how much compensation is there, how much do we need to move the teeth. And in average, it does take us about 1.5 to 2 years, rather 2 years many times, to finish orthodontically really well, to remove all the compensations that are built in the system initially, in the teeth initially, and give a very good, stable final result.
And I would say that patients must understand that even though it looks like a conventional expander because there are arms attached to the molar, the material of that arm is dead soft. So we're not really putting force on the molar. The other thing is that, and maybe you can share your experience with this, at what stage would you like to cut the arms off? Because patients feel more comfortable with that. Can you also touch on what sort of time frame do you find when you stop expansion that there's bone remodeling and then new bone formation?
Yeah. Yeah. I'm happy you bring up the arms and the effects we might have on the teeth. And there's always a question there. Why do we do it? Do we really need them? Because they see other expanders and they don't attach to the teeth. For us, we notice that, first of all, the arms are a guidance for us when we insert the MSE, allowing for quite precise positioning of the MSE. Additionally, it stabilizes the appliance during the expansion, not by pushing the teeth or anything, but avoiding a twisting of the appliance under the pressure, or like a better regulating the bone in the movement. I like to cut the arms usually when the expansion is finished, or of course, if we notice there's any side effect from them, if the patient feels very uncomfortable with them or has problems on cleaning with them. And normally the MSE, it's bone driven, so it's really inserted in the bone, so it's fine if we cut them, but we give up some of the stabilization effect we might have for the twisting. And again, as you mentioned, we monitor very closely if there is any tipping on the teeth, and if we notice, this would be a moment where we start cutting them and just release them.
And I think I also stress to patients that they won't have the MSE in their mouth for the duration of treatment. So including orthodontics, depending on the expansion, we're looking at 18 months for a simple case, maybe 2.5 years for a more complex case. But the MSE, once the bone has healed, we take out the whole screw. And many people, I mean, what can I say? Google can be good and bad. And I get a lot of patients who come in really who've Googled everything about expansion in adults, and they want to know, why should I go with you, Dr. Mahony, who pushes the MSE, whereas all these other people who do MAPI? Can you possibly help educate those people the difference MSE and MAPI.
Yeah. MAPI is a general concept of mini screw supported expanders. So it can be any type, it can be any expander. And MSE is a specific type of expander with those mini screws. MSE has the advantage, there's a lot of research on it. We exactly know how it works. And this is something I value a lot in my clinic, because if I do a treatment, I want to know what will be the outcome. How predictable is it? What will be the effects I have? And with other expanders, we don't know so much. There's not enough research on it. It doesn't show. And so I can only speak for the MSE that I truly have those midfacial effects. While I know other MAPIs claim them, maybe they have them, maybe they don't, but we don't know really. We don't know for sure. And that's also why I stick with the MSE. I know there have been other expanders pushing into the market. I think one that is spoken about a lot is the FME. And many patients do ask me, oh, Dr. Chris, do you use this one? Can we use this one instead of the MSE? And at the moment, I keep watching the development of it. They have the first version on the market. And from experience, I would at least wait for the second version. There's always revisions on it, improvements. And if you look at the screw positions of this appliance, it's very much in the same place as the MSE is. So for me, there is no mechanical difference compared to the MSE. Maybe the appliance has a different strength within it. I don't know. That's not so visible, but there's no study on it, not showing all the claims they make it's truly doing it. So I'll stick with the MSE at the moment until we have more research or we see otherwise.
And just for people to know, the MSE2, the arms from the screw come out at a greater angle, so you can use it in patients who have even palate. I'm looking forward to the FDA trials to be with MSE3, because we all have those patients who, when we do our planning, which I'll talk later about planning, I think that's really important, that we just can't even get the MSE2 in that position. I've tried some things like using a standard expander and just turning it really slowly so that we get some remodeling so I can then get the MSE in. But I think MSE3 would be a good solution for that. Now, as you know, you go to the AAO meeting regularly, so do I. Every second company is pushing aligners, right? And patients just think, why can't I have Invisalign expansion, right? Do you want to just share with us how MSC is different to traditional orthodontic expansion?
Yeah. Of course, there is we're saying it already, we're talking about MSE. It's a big difference what kind of expansion we can create with aligners or the traditional tooth bone expanders versus the skeletal anchored expanders. And it's like with the tooth bone expanders or aligners, we push the teeth, and there is always the discussion, do we have bone remodeling? Does it follow? And maybe it does. Maybe we can widen the jaw, the upper jaw size, but it's only exactly where the teeth are. It doesn't change the palate. It doesn't affect the midface. It doesn't affect the breathing. And I have learned over the time that when we see people with the small upper jaw, yes, we can push the teeth. But the problem is the underdevelopment of the whole midface. It's a three-dimensional problem, a development that failed when they were 6 to 10 years old, 6 to 12 years old, when all of this growth happens. And I can only recover part of this growth or a lot of it with the MSE appliance. With an aligner, yes, I can make the teeth wider, I can make the smile wider aesthetically. Maybe it's enough for some people, that's fine. But it is not the same effect as capturing missed growth as an adult.
Yeah, that's a good point. And I think, as you know, I do a lot of phase 1 intervention, mixed dentition. I believe in dentofacial orthopedics, where the maximum growth of that maxilla is going to be at 8-year-old. But then you see the adult who should have had that treatment and didn't, or you see the adult who's been nasal obstruction all their life and they've developed this what we call adenoidal face. So absolutely, they need more than dental expansion. So thanks for answering that. Would you describe to patients what are some of the visible effects of MSC on that facial structure?
Yeah, so let's say if we don't talk about the gap between the teeth, the diastema, let's
Yeah.
leave that one aside. What we always see is the mid phase after the expansion. It looks not older, but it looks mature. It looks healthier. And this is something we're trying to put like a point on exactly where is it coming from. And at the moment, we think it might be just different functions that are going on after the expansion. One is the maybe improved breathing paired with maybe better sleep. So the blood flow might be different. The tissue might be supplied better on oxygen. We don't know, but that's what we think. But for sure, we know that the underlying bone structures have changed. So they have become wider to some degree. Depending on the amount of expansion, it might be 2 millimeters per side, 3 millimeters per side, which is in total still quite some amount. And this stretches the tissue, as you mentioned, like a brace lifting or like a orthodontic lifting. And this effect is something unpaired of what we have seen before in orthodontics. And many times shiners under the eyes become less because the bone volume is actually coming forward and being pulled into the position where it's supposed to grow. And that's why the facial appearance of the people is usually healthier. And we see the same thing you mentioned with the patients. They meet their friends and they say, "Oh, what have you done? You look good. You look healthier. What's going on?" And this is a very common effect we notice after MSE expansion.
And if I was to be talking to a patient, and obviously, particularly in Australia, where we have a lot of patients who, want to know things like what's the guarantee it'll work? Tell me about your percentage success rate. And I've obviously always quote some of the classical papers where they divide the suture from an A to an E, with the D's and E's being less predictable. I always say males harder to split than females. Brachyfacial, and for the common term for that would be the square jaw individual with the big muscles. They're always going to be your higher risk patients. But if you were to put a percentage, how would you answer that question? So the question is from the patient, what's your success rate with MSC?
Yeah. In my clinic, we divide the success rate depending exactly on these groups, because I think you will be mixing pears and apples if you just put them all in one pot. And if we work with a 20, 25-year-old, of course, the success rate will be almost 99% if it's done right. While if we work with a 40 or 50-year-old, yes, it is a big difference if we have female, male, square face, or sometimes also we notice ethnicity does play a role in the strength of the bone and the connective tissue underneath. And depending on these factors, success rate for, again, 25-year-olds is almost 99%. For those at age 40, we see for females, maybe 80%, 85% of success rate. And for males, it's slightly less, depending again, square-faced people, maybe 60%. If we have more dolichofacial long faces with weaker muscles and maybe softer tissues underneath, maybe it's around also 80%. But we as well always, once we reach age 30, when we see those patterns that give us risks, we talk about, we attempt the expansion with the MSE by itself. In many cases, it works, but if it doesn't work in your case, we can have a surgical add-on assist to have a successful expansion while maintaining the effects on the breathing, on the midface expansion. And this is something we always talk about if we see there is the chance of not having success. Even if it's like in a very small percentage, then we start talking about this.
And I think in one of our previous interviews or one of our lectures together, we do ascribe to our profession surgically assisted MSE, where, of course, the term that's come out of UCLA or Stanford is DOME, where we're effectively combining the MSC with a Lefort. But more commonly, we use the ease procedure where the release is more anteriorly. As you know, microperforations on the suture helps loosen that. So there are various things we can try. But I always say to my patients, there's never 100% guarantee. But if we start non-surgically and then we have the surgical add-on, which it's great. And honestly, the hardest people to convince that MSE works are the maxillofacial surgeons, because to them it's like, are you kidding me? That's a surgical Lafort, blah, blah, blah. But when you show them cases and they become your allies, they are your best allies, because they will recommend now MSE first. And if it doesn't work, then they add to, and of course, the healing quicker when it's done this way. And I make the point again, when people do standard what's called surgical expansion, again, a lot of that expansion is occurring at the level of the teeth. With MSE, imagine it's not this expansion, but reverse that this way. And that's why it's such a big one for from breathing. Now, we talk about planning, and I know you and I came from an era where a lot of the planning was really done on study models and the depth of the palate, etc. Now, of course, we have CBCT, which allows us to really look at where the cortical bone is for both the palate and the nasal cavity. Can you just describe now how you're planning your MSCs to get the best of the analysis of the anatomy, the nasal airway, and also to determine the potential expansion you may need?
Yeah. You brought it already up. The initial phase of all of these expanders was done on a plaster model, and it was something to start with. But of course, we keep evolving, and we try to use digital data to be more accurate and more precise. And this increased the success rate of the expansions a lot, I have to say. In our clinic as well, we use 3D X-rays, CBCT, to have a full face scan. We look at the thickness of the bone, we look at the parameters around the palate, thickness of palatal bone, many factors to find the ideal positioning of the MSE. And so we virtually on the computer position the MSE in the spot where we know we have the center of resistance of the upper jaw, we have the good engagement of the screws in bone. And if we notice maybe at the ideal position of the MSE, the bone is not good enough, we can add additional mini screws for individualization and stronger bone support. And based on this positioning, we see exactly where's the mid-palatal suture, we see symmetry, we see asymmetry, and can match the MSE exactly to it. Sometimes the palate looks fine and intraorally when you look in the mouth, but on the X-ray, you notice the bone underneath is crooked. And then we need to plan with the MSE and design it to follow this and even out the force vectors and maybe shift the screws on each side to have different force levels on left and right. That's what we try to do at this moment. And then we can manufacture the MSE based on this. We like to use the 3D laser printed metal because it's just very clean and nice to place. However, many times if it has to be very quick, we still use conventional bands as they are just to insert the MSE and guide them, which is still very good for us. And then we can exactly place the MSE in the mouth where it belongs, where we have the good bone, where we have correct orientation of the MSE. And this, again, secures a very high success rate.
And I'm noticing now One Moon, and I think I'm right in saying the Moon Lab
Yes.
almost developed AI technology to help with this. So I've just started using that.
Yeah.
I've gone from pretty much using the original lab in Korea. They did a great job, but very much were based on looking at the model to going to computer guided thing, and now using the AI learning from all the cases you guys have done is truly amazing. What about the question people say to me, Dr. Mahony, what percentage improvement in my breathing should I expect if I get the split and if this goes well and if I get the expansion that you talk about?
So of course it's difficult to predict how much effect will there be on the breathing, because breathing is related to so many factors, and changing the width of the nasal cavity is one. But there are other factors involved, like how thick is the mucosa? Do you react maybe to some allergens? Does it swell, de-swell? And so many times we recommend the patient to try some nasal spray first. And if they notice improvement, many times we say this is around the range the MSE can do, usually maybe some more even. And then patients notice that. We do also measure the amount of air that can flow through the nose. It's a clinical test we do on every patient before and after the expansion. And depending on, again, on the amount of expansion and on the patient, we see sometimes 50, sometimes 100, 120% improvement on that, meaning you double the amount of air you're able to breathe through your nose. And this is a game changer for many. I recently had one patient from Scandinavia, from Norway, actually. Was a police officer, and she loved field and track running. And so in her spare time, she was very competitive doing those runs. And the other time I was having a call with her after the expansion, and she told me, Chris, yeah, it's good, the breathing. I noticed some, but I wasn't aware so much. But the other day I had a competition, and the first time in my life, I was able to breathe only through my nose throughout the whole competition.
Wow.
I need to change my training, because now not my breathing is the limitation, my legs are my limitation now.
Right.
So,
Yeah, that's great.
this is what people report, and that's something we cannot predict at the moment, but we're
So
working on it.
a lot of the cases I plan for MSC come from an ear, nose, and throat doctor. Uh, One thing I will say to the audience is, if you are about to have a septoplasty and you have a narrow maxilla, it only makes sense to do the expansion before the septoplasty, because the thing about building a house, and you're putting up the framework, which is the septum, but the base of that septum and the base of the framework for your house are the foundations, which is the palate. And Not that I promise this to patients, but I've had patients who have mild septal deviations, and after MSC, even though the septum is not fully straightened, there's more airflow on either side. So the need for the septoplasty is greatly reduced. Having said that, planning some of these cases with my ear, nose, and throat doctor in a really deviated septum, I've probably got more risk of facial asymmetry, because that cortical plate goes into thicker bone on the deviated side of the septum and almost acts like a reverse anchorage unit. So I think that's a good research area to look at. What percentage airflow and what percentage need for septoplasties will there be in those more difficult cases? But you're absolutely right. People who came in and wanted MSC for aesthetic smile, one thing that they notice is their breathing improves, and when their breathing improves, of course, their sleep improves. So I think that's why it's not so much an MSC technique or an MSC appliance. I think it's an MSC philosophy is what we talk about. Now, more and more people understand that not only is their jaw narrow, but their upper jaw is much further back than it needs to be. So with children, as you know, as an orthodontist, we can employ face mask therapy, and that bring the upper jaw forward, which also helps with breathing and facial aesthetics. Can you use MSC with a face mask?
Yeah. We have the request for many patients if they can combine, adult patients, if we can combine the MSE with a face mask. And yes, we can, definitely. And we have seen amazing effects, especially, I have to say, in 12, 13, 14-year-olds. In adults, it becomes more difficult to create those effects. And with the MSE, we combine the so-called Alt-Ramic protocol, meaning we open the MSE and close the MSE to additionally stimulate the sutures. And then adults can use the face mask. We normally don't use the conventional face mask for adults, which goes from the forehead to the chin. We rather use a stronger version, a face bow, which goes from the forehead to the chest and allows for very high forces to pull on the upper jaw. Some people have success, some people not so much. I think it highly depends on their wear time. And we'd like to see, ideally, in an ideal world, for someone to wear this all the time, like a cast after breaking your arm. Realistically, this is not possible, I have to say. So we encourage everyone to do as much as possible, but many people get challenged in daily life using this face bow in daily life, in going groceries, doing the work. And so the wear time shortens, and then it's difficult to predict how much effect we will have. I don't know,
And
how is your experience with this kind of...
again, I have some patients who are so motivated, particularly some of my patients who work from home, the housewife looking after their children, and they kind of wear this thing 20 hours a day. And I had one lady who listened to my instructions on the force of the elastic, and she doubled her elastics up, right? And let me tell you, and on that point, when we're editing this podcast and the YouTube, maybe here we can put a link to Won Moon's recently published paper in the American Journal, where he shows this amazing case of a young lady. I think she was 25, and everyone had told her she needed jaw surgery. She was so motivated to avoid surgery, she wore this face mask like you wouldn't believe, and the results are spectacular. In fact, I think when he initially submitted that paper, everyone thought it couldn't be true, right? So yes, in my hands, face masks do work. And I'm using now the Khan face mask. Is that the one you're describing?
Yeah.
And the Khan face mask works for me for older individual much better than the traditional Dallaire or Petite face mask. And again, if people want more information on that, we have a whole section just on face mask therapy. But that's great. So yes, MSE can be used with face masks, but you need those sutures to be loose before you start pulling on the jaw. And the alt-Ramek technique, which is used in adults and children, is a very effective way to really get those sutures going. But remember, when you're doing the traditional expansion with an appliance fitted to the teeth, you're not loosening the same sutures as you're loosening with the MSE. So you have more circummaxillary sutures, and that's why you are able to get that whole midface brought forward. Now, as you know, one of the big gurus in the field of skeletal anchorage is our friend Benedict Wilmers from Dusseldorf. Nice guy. And he pushes on having his expansion at the anterior part of the maxilla because he's shown that the quality of the cortical bone in that pre-maxillary palatine root area is very thick and strong. Can you to the audience why the research has shown that for the MSE to be effective, it's better to be placed at the back of the maxilla?
Yeah. This is I think a big big discussion going on between also Dr. Wilmers and Won Moon. And I know both of them well. And of course, both have reason to say what they're saying. And of course, the bone in the anterior palate is stronger, it's thicker, it gives more stability compared to the mid-palatal bone many times in the backward area where we like to place the MSE. And this is something we discuss about a lot. Why we place it all the way in the back, knowing the bone might be softer, is we want to move the screw to the center of the resistance of the maxilla to create what we call a parallel split of the palate, meaning we open the front and the back about the same amount, meaning we have the same amount of effect on the entrance of the nose and on the exit of the nose, opening the whole nasal airway all the way, maximizing the airway effect. While when we have the expander more forward positioned and the screws more forward positioned, we are more prone to creating what we call a V-like expansion, meaning we create more space in the front, less in the back. And if the constriction on the airway is only in the front of the nasal cavity, then yes, this will have an effect on breathing. Of course it will. But it will not affect so much the back of the nose. And this is something we don't like in our clinic. We'd like to have the parallel effect. And that's the big discussion going on there. And I think it depends on what you'd like to achieve.
And can you share with the audience, either if they are doctors placing MSE or patients doing the treatment or thinking about the treatment, tell patients to expect in the first few days? What's it going to feel like in their mouth? What are some of the post-placement instructions you give to patients?
Yeah. So the MSE is placed under local anesthesia, so you're conscious all the time, and it does take around 30 minutes, 40 minutes, plus then some instructions on how to use, how to clean. And we do give pain medication after MSE insertion. I think one part that is quite uncomfortable is the cortipuncture we do in adult patients. And so for the afternoon, we recommend to take some pain medication, get through the afternoon, and that's about it. Next day, usually it's fine. And then when you start activating the MSE, you feel pressure throughout the palate and the midphase, which lasts a minute to 5 minutes and then subsides, goes away. And then for most people, the expansion is quite comfortable. They don't notice so much. The biggest adjustment, as you mentioned before, is like taking away space for the tongue, the appliance itself, and getting used to eat with the appliance initially. It might be more challenging to eat small grainy food. Like the other day, I had a patient, she said, my worst enemy was a good done risotto, because those little rice pieces, they got stuck everywhere. And
Right.
so I recommend to have something you can cut, something then you can eat, and that's usually fine. So the adjustment phase for the MSE is about 1 to 2 days, plus then maybe 2 days for eating, swallowing, and then it's usually fine.
And, you and I both have patients who fly in just for this procedure. What's the minimum time you suggest they don't fly after you place the appliance?
So yeah, in our clinic, we teetered the whole treatment process exactly for those people, because we have to work differently than with a patient who lives around the corner and who can come to our clinic within 10 minutes. So for these patients, we usually try to condense all the appointments as much as possible and design the clinic accordingly to these needs. So for those patients, they usually come in a 3-day sequence the first time. On the first day, we take all the records, we scan everything, we check all the treatment plan, we make sure everything is exactly as we have discussed beforehand online. And then we manufacture the MSE, place it on the second day. And on the third day, we do a checkup just to make sure they know how to clean, they're comfortable with it, and then they can fly back home. So for us, it's basically we insert the MSE, next day we do a checkup, and then they're able to fly back home. And we monitor everything remotely from there on until they return, usually after the finished expansion even.
Right. Chris, many patients want to know, if they undergo MSC and it is successful and they get the split and they get the improvement in the breathing and everything we've talked about, how stable is it? How long will that new bone last for them? Will they have to have another MSC later in life?
Yeah. So overall, we know MSE expansion is very stable. As we do change the bone structure itself, it stays usually very much in this position. Of course, we always encourage to adjust the functions, keep the tongue up on the palate, nasal breathing, to ensure long-term stability overall. But we know MSE expansion is very stable. How do we ensure it stays that stable? We know that after the expansion, bone has to fill in the mid-palatal suture. So one benefit we use is doing the expansion slowly, bone already has time to grow along. And at the end of expansion, we already have partially maturated bone. Additionally, we know that the first bone healing phase, the overturn rate, is about 3 months. So after we do the last activation, we wait for the 3 months. But we know it is not fully healed at this point. So we'd like to keep the MSE at a minimum for another 6 months in to allow for more solid bone to fill in. If people are comfortable with the MSE, we can leave it longer. But we know after 6 months, usually it's quite stable. Additionally, one thing we need to consider is it's not in the traditional way of orthodontics in children where we do the expansion and that's it. In adults, we also have bone remodeling all around the zygomatic arches, around the eye sockets. All the bone has to rebuild. And that usually takes as well 6 months as the bone is readjusting to the new stress. That means when you eat and chew, all of this bone has to remodel to fit the new pattern of your palate, to fit the new chewing behavior. And that does take about 6 months. This is why we leave a minimum of 6 months. If patients are comfortable, we're happy to leave it longer.
Great. Now, as you know, my practice and yours focus a lot on the treatment of obstructive sleep apnea. And in the literature, one of the most stable corrections is an MMA, which I'll describe for the audience is a upper and lower jaw being advanced forward, known as a bimax or maxillomandibular advancement surgery. But a lot of the surgeons who purely do MMA have now switched to doing a first phase expansion because they find they get much better airway doing it this way. But for the poor old patient, that's actually two fairly big surgeries, one to widen the maxilla and the other to move the jaws forward. Are you combining MSE with any of your MMA surgeries?
Yeah. It's a good question. This many times come up. Those are things, and we have to consider why are we doing those things in sleep apnea patients, especially. And if we are honest, for sleep apnea, currently our big major treatment is to increase the airway volume in any way by using advancement appliances, any surgical procedure, reduces soft tissue, anything, by jaw surgery, moving just things forward to open up the posterior airway. And of course, MSE expansion, we widen the nasal cavity. So for me, those things go together because just moving the jaws forward, we miss out on the nasal cavity. And most people do need the combination of both because again, development, growth happens on all structures at the same time and usually they are adjusted to each other. So I barely ever see someone with a perfectly nice, well nasal cavity, big one, and having sleep apnea with a small lower jaw. Usually this doesn't happen. And so we usually do the MSE expansion first and allow for the initial bone healing. And then we go into the bi-jaw surgery if it's still indicated. We sometimes have people who are on the mild scale of sleep apnea. And after the MSE expansion, their sleep improves so much that they basically are healed and they don't need the bi-jaw surgery anymore. However, we always keep that in the loop and say, of course, if it doesn't improve sufficiently with the expansion by itself, we go into the MMA surgery afterwards. I want to stress at this point, do the expansion first and then do the surgery, because after surgery, there are scars on the bone, there is unpredictable bone healing, and it might make the MSE expansion more risky to do it after the bi-jaw surgery. So if possible, do it first and do the MMA later.
Now, a lot of patients and a lot of people through the internet ask me a question on what is my expansion protocol. And obviously, I have a higher rate of expansion before the split and I slow it down after the split. But really, it's customized based on the patient response, the patient's anatomy. Could you share what your typical protocol would be for expansion with MSE?
Yeah. Depending again, as you say, on the age and the effect on the patient, we individualize. But the standard protocol is that we go slowly as well in the beginning, giving the suture time to react for the cells to get active. And we go with maybe 2 activations per week, meaning about 0.3, 0.4 millimeters of activation. And as soon as we notice the split, we usually like to go up to maybe 1 activation per day, meaning about 0.8, 0.9 millimeter per week, depending on how the bone reacts, how they feel with the tissues. And if we are in a risk patient, we might stay on a very slow expansion to allow for the bones to adjust and bend under the pressure. We noticed when we kept going with fast expansion in the very early stages of skeletal expansion, that if you build too much pressure too quickly, bone might fracture. And this is something we try to avoid by going slowly and adjust to the individual response.
And I don't think anyone still uses the original MSC screw, which was the little jack screw or the hole where one turn was 1/4 of a millimeter. One came up with the hexagon, very much like tiger screw or super screw. Can you just explain to the audience 6 sides? If you were to turn one of those 6 turns, how many millimeters would you equate that with?
So on the MSE2 with the hexagonal activation screw, we have about 0.13 millimeter of activation per turn. That's why doing 2 turns is around 0.3 millimeter of activation.
Perfect. And post MSC, do you have a preference between closing those spaces with fixed braces or using clear aligner therapy? Because obviously the MSC patient tends to be an older individual, tends not to want to show braces.
Yes. In our clinic, we like to use aligners for all the patients who live further away. They bring us many advantages in the sense of it's easier to control long distance, it's more convenient for them to wear. And it did take quite some development of the aligner protocols to manage this really well and ensure good space closure and ensure good occlusion and everything. If we have patients who live in Munich, who are in close reach, we are open also to do it with braces. And of course, many movements are easier to control sometimes with braces. And sometimes if we have an adult patient who is going to wear braces anyways, we put braces on the front teeth on early and try to avoid the diastema early on. And that's an advantage we sometimes can do with braces if they live locally. But again, if they live abroad, if they live further away, it is not feasible in our sense that they visit us maybe every 8 to 10 weeks. And that would be a lot of traveling. Then we use aligners.
And I think people should also understand that the orthodontist who understands MSC should probably be the same doctor moving your teeth after MSC. Why? Because an average orthodontist sees lots of gaps and will reach for power chain and kind of just close all those gaps and constrict all the hard work we've done. So I try to explain to patients, once you have MSC, you're maintaining that wide circumference, and it's almost like sliding beads on a necklace. We're moving all the teeth forward and together. And the other tip I always say to get those front teeth bodily coming together rather than tipping, we try and put our force activation much closer to the center of resistance. And if you look at my YouTube videos where I go through patients stage 2, to me, stage 1 is the expansion, stage 2 is the tooth movement, and stage 3 is our retention. But I have some good YouTube videos explaining that tooth movement. Now, we've talked about what happens if the suture doesn't split, and then we're looking at a combined surgical approach. What about millimeters of expansion? I don't know about you, but every month I get more patients coming in with a figure in their head. And they seem to have, I don't know how they do it, but they seem to determine that they're an 8 millimeter or a 10 millimeter or a 12 millimeter case. Can you share with us what is the average expansion you should expect? I know it's based on bone density and the patient response. What's the maximum you've ever expanded? And please explain to me, because I can't figure out how patients have determined their own expansion.
Yeah. For
Sorry,
me,
that's a lot of questions at once.
First of all, I also hear this, I would like to do a minimum of 10 millimeters. And this is again, I don't know, I'm not sure how they get up with the numbers, of course. But how we work in my clinic, we measure usually the amount on a CBCT. So we look at the bone level, we measure the width of the bottom jaw, and then we calculate how much wider should be the upper jaw to match well. And we ended up with a percentage of about 10 to 15% wider top jaw compared to the bottom jaw. So it fits like the lid on the pot and exactly matches, and it allows to move all the teeth into good positions within healthy bone. And that is what we saw. These numbers come from different studies from anthropology, actually, where they've been looking at healthy human beings without crowding, good jaw sizes, no orthodontics needed, and that's where this number comes from. And so it depends. If you start with a very restricted, very small upper jaw, maybe yes, we do need 12, 14 millimeter of expansion, which is a lot. And my widest expansion at the moment was about 16 millimeters. And this does give a hell of a diastema, I have to tell, a hell of a gap in the front. And I recall that the patient came back, it was during COVID times, and she came back with a face mask on from the flight, being welcomed at the reception. And she was so proud of the amount of expansion she had. So she pulled down the face mask and smiled at the receptionist. And the receptionist wasn't prepared for that. So she almost fell from the chair looking at that. And it's still an amazing case. And she had great benefits, of course. But the number needs to be determined individually. And I would say most people are in the range between 6 and 10 millimeters. This is something most people end up with. And only severe cases usually go beyond that.
Yeah. And you're talking about COVID just then. In Australia, our practice was busier than it's ever been. Why? I call it the Zoom boom. I think people, when they're on Zoom, because no one even knew what Zoom was, right, before COVID. And then everyone's an expert on Zoom. And on Zoom, of course, you're looking at your teeth and your face for so long in so much detail. I think people really say, wow, I'm gonna and then the other thing is we didn't care how much diastemas because the masks were there. It was perfect time to do MSE, to have braces versus aligners. So that's a good one. Now we're going to talk about asymmetry, and we could almost do a 1 hour podcast on that because that's my biggest question and discussion with patients, right? But before we do you get, as you know, with children, when you expand, you do also get some natural protractions. The maxilla does come forward. In all your CBCC studies in your private clinic and also when you were studying your research at UCLA, what sort of, if any, forward movement of the maxilla do you get just with normal standard MSE without the face mask?
Yeah, this was a big part of the studies we did at UCLA, where we came out with the papers, published the good effects we have with the MSE in a very detail. And we noticed that the upper jaws don't just slide left and right, they just don't expand like this. They rotate, and with the rotation, they swing like a door, they swing open, and they do come forward. Again, depending on the amount of expansion, we usually see 1.5 millimeters to 2 millimeters of forward rotation of those maxillary halves during the expansion. And thus implements that we have all the benefits of bringing the upper jaw forward with the MSE, but without the face mask. Is 2 millimeters a lot? Is it little? That depends on the case. For some people, it can be life-changing. For some people, they don't notice so much. And it depends very much where you start from. And if your airway is very compromised, if your tongue space is very compromised, and your breathing is very restricted, 2 millimeters can be quite some distance.
And say you have the world's best face mask patient who wears it exactly as directed. It's been designed correctly, the correct face mask, the correct vector of pull. How many millimeters are you anticipating of the maxilla to come forward MSE face mask protocol?
Yeah. We are still working the exact numbers out. We're collecting data and we are looking into it. So my professional guess, I would say as well, in the sense, would be maybe additional 2 to 3 millimeters would be a lot. If you add those numbers up, it would be incredible, amazing. But this is something difficult to reach.
Now we're going to talk about symmetry. And of course, as we know, not anyone in the world is perfectly symmetrical, right? But
Yeah.
possibly once you expand and you line up the teeth, some of those mild imperfections become more obvious. Can you tell me, can asymmetry be prevented during this procedure?
So I totally agree. Nobody is perfectly symmetric. And I tell every one of my patients, every expansion we do is asymmetric by nature. So the question only is how much asymmetry on a scale? Is it little or is it completely asymmetric? And in most expansions, we are on a very small scale. So sometimes we notice intraorally that there are differences between the incisors happening. And yes, we know one side is moving slightly different, but in the mid phase, you don't notice because the effects are too small. And I always ask my patients to keep watching themselves in the mirror. Use a piece of paper, block out the lower jaw and the lips because they will be crooked during the expansion. They will throw off your perception of the mid face. And then look at the mid face, blocking out the lower part of the face. And then look at the mid face. Your brain will be the best tool to notice any asymmetry. It has looked at your face for so long, it knows exactly if there's something going on. And if there is an amount of expansion you notice it's uncomfortable or it's something you don't like, you can always stop the expansion at this moment, reconsider, double check, and decide then together with the patient we do it. Do we continue or do we stop at this point? And this is usually how we address starting asymmetry. One thing we also like to look at with asymmetry is through dental monitoring. We do a 3D monitoring during the whole expansion, being able to measure millimeter changes of each tooth in each direction. And if we notice any more than a millimeter of asymmetry, we usually reach out to the patient and ask, oh, please double check on your face. Do you notice anything? If they say, no, nothing, then we say, okay, it's fine, keep going. And that's something we work with. Of course, we also have cases where we have a complete asymmetry to one side. If this happens, one can do a surgical weakening of the stronger side to facilitate more movement of this exact same side, to create more symmetry. But this will never be perfectly symmetric, of course, because the cuts will not be the same as on the other side. There's no cuts on the other side, and you will end up with some part of asymmetry.
And I think, and here we are going to upload paper by Juan where he discusses about symmetry in MSE. And what he mentions quite correctly, majority of obvious asymmetry of patients' faces is actually the lower jaw. It's the mandible that's off to one side. And I always look at my x-rays and measure ramal height on the right and left. And if a patient has a higher ramus height, one side and the other, I always warn them that MSE will not fix that, may even worsen that. And it's something that we already prepare them for a surgical procedure post MSE. So
interesting
I'll
note,
pop
maybe.
that.
One is interesting note to this part as well. When looking at many CBCTs, I discussed also with Juan Moon, and he noticed that usually the zygomatic bone is quite level and symmetric in all patients, no matter how asymmetric the lower jaw and the maxillary complex becomes. So there is a question of the growth. How much does happen from here? From which factors does it come? So that most of the adjustment happens underneath of the maxillary alveolar bone, what we call of the tooth-borne bone, and the lower jaw, like you say, the ramus height, the posterior height of the jaws, where we have most of the adjustment and asymmetry. So this is what we see many times when we look at 3D X-rays.
And what about we talked about the nasal valve and collapse of the nasal valve being one of the major problems in people's breathing, particularly at nighttime. Do you find the MSE expansion affects the nostrils equally?
Yeah. What we see is, of course, again, I'd like to refer back to the parallel expansion we are doing. And as we do move the foundation underneath of all this soft tissue, as we move the bone, we are actually widening the bone where all the soft tissue is attached, opening up those nostrils. Again, depending if the expansion goes fairly symmetrically, this effect will be on both sides. But if the expansion doesn't go perfectly symmetric, of course, one side will stretch more than the other. However, when we look at the nostrils before treatment, many patients already have asymmetric nostrils to begin with, and we will not see the MSE correcting this kind of asymmetry.
Right. So other than the obvious gap, how do you know, or how will a patient know that their suture has split?
Yeah. When we have the split of the suture, so other than the noticeable gap between the teeth, many patients report about very sensitive frontal incisors. So those teeth at the center will become quite sensitive after the split has happened. And when they bite into anything, they will notice it for a couple of days. Additionally, we can always do a radiographic checkup, seeing if the suture has opened. Some people do take a small X-ray just in the front to see the split. And of course, we do it through the dental monitoring app, which is fine for us because we start seeing teeth moving where the MSE is not attached. And this works on a 1/10 of a millimeter scale, so it's very precise, and that's usually sufficient for us. Patients also notice change of the bite at this very moment that is happening, and those are usually good signs for the split. Depending on the protocol you're using, if there has been pressure build up with the split, they will notice release of the pressure. And many times they suddenly feel like instantly they breathe better through the nose, and might be a stimulation of the nasal mucosa through the nerves attached that they deswells immediately, and they notice like, oh, suddenly everything feels lighter, it feels released. Those are things we hear from the patients. But this is like say subjective how they perceive it.
So let's talk about maintenance of the MSE. Of course, keeping it clean is the most important. And I have had one or two cases where the patient's oral hygiene hasn't been good. And of course, the swelling. And the worst thing is when the arms of the MSE embed in the soft tissue. What tips do you give your patients as far as keeping that MSE clean during the treatment?
Yeah, we ask them to brush it rigorously with a normal toothbrush. They can touch it, they can push the bristles underneath the MSE. It's all fine. It's very stable, robust. It's perfectly fine. Additionally, we always give them a water pick so they can spray underneath and shoot food remains out underneath the MSE. And I even ask them to use some chlorhexamate to do those rinsings with the water pick, to have some disinfectant also like working around the MSE. And this usually works really well. Additionally, sometimes it's good to have a tweezer. Most people have a tweezer at home. So if something is stuck, you can also use the tweezer. And with this protocol, they're usually fine. Of course, we also had patients. One I remember, actually, she didn't stop smoking, and we had a poor failure of the MSE where screws were coming loose, probably due to the infection caused with the smoke, combined with not ideal hygiene. And this is definitely also risk factors I would consider. Stop smoking during MSE expansion if you smoke. Stop smoking at all. Usually, that's always the doctor's recommendation. But definitely doing it.
And of course, patients always are worried about if they can eat after the MSC has been placed and when can they return to a normal diet. Can you offer comments in that regard?
Yeah. As we have talked, of course, after the placement of the MSE, there's less space for the tongue, and you will have to get used to swallowing with the MSE in. So eating will be more challenging. Theoretically, you can eat anything you like. It's fine for the appliance, it's all good, but chewing will be compromised or will be less effective with the expansion going on. Your teeth won't be touching well, so maybe a good steak is not the best choice at this moment. And usually anything you can cut small is perfectly fine. Just cut it and you can eat.
Do you, when we talk about chewing with my patients, I always tell them towards the end of the expansion and before I start the orthodontics, they'll have a really weird bite because it's what we call a scissor bite or Brody bite, where, the upper teeth are now wider than the lower, almost the opposite of that analogy you gave with the lid on the pot. With the question people ask me, Dr. Mahony, we get expanding the upper, but why are you not expanding the lower jaw? Can you explain? Well, I have to tell the patients it's very rare we expand the lower jaw, because there's no suture, so there's nothing to open up. And if we have to expand it, then that is distraction surgery. But can you explain why it is that even with 10 millimeters of expansion in the upper, we can still have a good bite because the lower teeth are uprighted, and that is the expansion.
Yeah, absolutely correct. That's what we do as well. We usually upright those lower teeth. We looked very well into the question, how do we know if this is sufficient? Why do we know this is sufficient? And there is something going on, we are still, I have to say, understanding, is like the lower jaw, it usually grows well in width in most people, especially in this area where you have the chewing muscles, the masseteric muscles attaching. We have still forces going on, we have still good bone growth, and we assume that this determines the width of the jaw a lot and helps to develop the jaw well in most people in width. We see a lot of alterations in forward growth. Many times the amount of growth is good, just the direction is not ideal. Many times it's grown downward into what we call a class 2 long face syndrome, or it's grown too deep forward. But the total amount is still good, just the direction changes with the functions a lot. And so based on this, we measure the width in the first molar area, close to where those muscles insert, where we have a good bone width. And that's why we see in most cases this is sufficient. You mentioned distraction osteogenesis for the lower jaw to make expansion, true expansion on the bottom jaw, skeletal expansion. And we have done this a few times at UCLA as well. But I need to mention that at UCLA, we were treating a lot of craniofacial patients. They were coming from all the area of California because UCLA has a big center for craniofacial patients, integrating many disciplines to provide good care for them. And only we saw small mandibles if there was a true genetic defect. And this is when we applied the lower jaw expansion.
Also answer when I have a class 2 patient and we expand the upper, that mandible tends to come forward because that's how they have to chew. And I try to explain to patients that even though the mandible has not changed in width, when the mandible comes forward, it actually becomes wider. And so that with uprighting, I've never had a case where I haven't been able to finish into a normal bite because we didn't expand the lower jaw. So thanks very much for taking the time to deep dive into MSE. I think, when I think back in my 40 years in practice, probably MSE is up there with the most exciting new technology that I've ever used. It's a game changer in the way I practice. I went from not treating adults at all to, and I always say to orthodontists, you can't use the same principles of orthopedics and orthodontics you do in children in adults. And unfortunately, I do get a lot of people through social media who try and tell me that they're 35, but they want to have a BioBlock appliance like the Mu philosophy because they can still get growth of their jaw. And I think one thing MSC has done, it's allowed me to offer what I do in children to non-growing individuals. And that's what makes it so unique. Who knows what the brave new future will be and what we can achieve with things like distraction. But I think Juan Moon has done a wonderful thing. And he's such a humble guy, but he travels all around the world spreading the word. And I've never had a doctor who's properly done his course and done the technique exactly the way he did and hasn't had success with his patients. And, it's almost like he's become like a little religion in himself, right?
Yes, yes.
We, as you know, we had a new pope elected today, and first time ever it's American. And I don't know whether Trump had anything to do with that, but I think one person who doesn't need MSC is Donald Trump, right? His mouth is big enough. So, uh, so
Yeah.
we'd
No,
like to thank you for your time. I know you're just recovering from a head cold, so I wish you speedy recovery. And we'd like to possibly, once we get feedback from this podcast and YouTube video, when we have common questions, maybe we might do just a special segment. Particularly, I know symmetry will be a hot topic. So how do you calculate the amount of expansion? And I think another topic would be, contraindications of MSC. Maybe we could end with that last question. What patient would you not perform MSC?
yeah. Um, I would not perform MSE if there's, of course, any general medical conditions that make a contradiction. For example, also
Yeah.
osteoporosis, if they used any medications that stops bone remodeling. Those are like off job. Orthodontic contraindications, you have to look into having a wide enough palate at the moment. We're looking for MSE3. We're waiting for it to be able to do it better with also those ones to have it.
Mhm.
And non-compliant patients, like those who don't follow the instructions, because then it can become risky if they do their own thing. It does need some experience and guidance to do it well. And yeah, otherwise, healthy tissues, healthy, good oral hygiene, and good basis to work with together is mandatory for us.
Perfect. And I think I'd add to that list pregnant women. We tend to stay away from that. I've tried a few cases that have maxillary tori. And what's your thought on that? Do you tend
Yeah.
to some school of thought is remove the tori and then fit the MSC? Others are just to place it through the tori. What are your thoughts on maxillary tori?
We do give it one attempt with a tori even, depending on the size of the tori. We still need a stable, good foundation. And you still have, if you look closely, you many times still see a suture running through the tori. So there is still the possibility of the opening. And so we usually know the chances are less, maybe a little bit, but we give one attempt with a tori. And that's usually how we address it. We did not send out to have the tori shaved and do the MSE after. We didn't do that yet. We didn't have to. So maybe you have more experience on that with those severe tori patients.
Perfect. Okay, Chris, thanks again. Look after yourself, and
Thank you.
my staff will probably want to get a copy of the published articles because we've mentioned this podcast, and we'll add them so that people listening don't have to do too much background reading, and hopefully this will bring some evidence to all the stuff on the social media about MSC. Thanks again.
Great. Thank you as
Okay.
as well.
Bye
Bye.
bye.